Hey everybody, welcome back to Spot Check here. I was thinking about the last video we did on porphyrias, and I found myself to still be, challenged by them even after doing the video, and even thinking back to when I was originally studying them, how convoluting they were. So I did want to add a few more questions just to kind of help hammer home some key principles. Now, I do want to thank Leo here. He helped make some of these PowerPoints, or make these questions in PowerPoints, and without him, it wouldn't have been done, to be honest. So let's go ahead and get right into it. A prerequisite, unless you have a foundational knowledge of porphyrias, would be to watch the porphyria lecture that we kind of talked about and did. But if you have studied it in the past, you feel pretty confident, just want to use this as a little reminder, then more power to you. Let's get it going, okay? So we got a 45-year-old male presenting to the dermatology clinic with the chief complaint of skin fragility, blistering, and hyperpigmentation on sun-exposed areas. The patient reports a history of chronic alcohol abuse and mentions that his urine has turned dark on several occasions. Physical examination reveals bullae and erosions on the dorso of his hands and face, and milia formation is noted. Laboratory investigations are ordered, and they're right here below you. A little bit of liver inflammation, elevated ALP, urinary uroporphyrinogen, and fecal porphyrin are elevated. So what's the diagnosis here? Real straight up question for you. Obviously, we're in the porphyria section, so it's got to either be C or D. But think about the other diseases and why they aren't the answers. Laboratory investigation obviously helps you out with A and B being ruled out, and even E to a degree. So, and we got a 45-year-old, no mention of history of this as a kid, no mention of concomitant liver disease, no mention of, medication insult. So this is tried and true. It's porphyria cutaneous tarda, PCT. The highlighted things are the important things to note. So PCT can be, you see your skin fragility, your blistering, your hyperpigmentation, bullae and erosions, typically sun-exposed areas. Hands, dorsal hands are the most classic area. Chronic alcohol abuse can help you. Hemochromatosis can help clue you in as well. You can see these elevated liver enzymes as well as elevated urinary uroporphyrinogen can help you out. Now, the key thing just to kind of get familiar with, I don't say you have to memorize these on exam day, but, any chance you can get them, get an extra point will be cool. What's the enzyme? This one's probably one that you probably should commit to memory to a degree because this is such a common disease and test question. This one being uroporphyrinogen decarboxylase. Moving on, we got a 32-year-old woman who just immigrated from South Africa presenting to the dermatology clinic with complaints of blistering skin lesions and recurrent episodes of severe abdominal pain and constipation. She describes a long-standing history of these symptoms, intermittent exacerbations over the past several years. The patient reports that her sister also experienced similar skin manifestations. On examination, there are vesicles, bullae, erosions on the sun-exposed and face and hands. Additionally, hypertrichosis is noted. There are episodes of confusion and weakness that coincide with the abdominal pain. Neurologic exam reveals mild muscle weakness and diminished DTRs. So what enzyme do we think is affected? Any ideas? I'll give you some time to think about it. First, think of the disease that you want to pin down, and then try to pin down where it is in that chart. Yeah, that's right. It is a protoporphyrin oxidase mutation or deficiency, and this is variegate porphyria. So look at the chart in the bottom right, variegate porphyria, protoporphyrin oxidase is the enzyme just lateral to it, and it's a red enzyme, so that means it's a mitochondrial-based enzyme. Do note your skin findings are pretty consistent with PCT. However, you also have added neuro findings, and abdominal pain can be found as well. How do you differentiate this from PCT? Well, the enzyme helps. Sometimes you'll get asked about buildup, and if you know kind of roughly where the buildup of mitochondrial proteins start, or subunits start, and the buildup of cytosolic supplements or cytosolic building blocks build up, that will help get you clued in. So we know varicose porphyria is a mitochondrial disorder. Therefore, you're going to see a buildup of the mitochondrial subunit, protoporphyrin 9 in this case. PCT is a uroporphyrin 3 buildup in the cytosol because that is the one just above that enzyme. A 28-year-old female presents to the emergency department with severe abdominal pain, nausea, and weakness. Her medical history is significant for recurrent episodes of abdominal pain, and she reports a recent initiation of barbiturate therapy for insomnia. A mild hypertension is noted, diffuse abdominal tenderness is noted, muscle weakness, and decreased DTRs are noted as well. There are some significant lab values located below. That is elevated urine and stool porphyria. Porphyrins, and a increase in serum ALA as well as PBG. And then you have a plasma heme that is decreased. So what's the enzyme? Think of where ALA is. So first off, you got no derm findings. That's going to be key to you. So when you're isolating the disease, there's not many that have just absolutely no derm findings. And then think of where ALA is. Is it at the top of the cascade or at the bottom? Right? So it's at the top. So what do you think the answer is? Is it AIP? Right? So AIP doesn't have skin findings. It presents a little bit older, significant abdominal pain, and can be exacerbated by barbiturate therapy. So where is the enzyme for AIP? That's right. It is porphobolinogen deaminase. So here's AIP again. We already talked about some of the findings, but look at the chart here and where the enzyme is. The enzyme for porphobolinogen deaminase is right there at the beginning of the cytosolic components. So therefore, you're going to have a buildup of both porphobolinogen and ALA, which was mentioned in the question, as well as a decrease of heme because the rest of the cascade is not moving forward, and that kind of helps you clue in. All right, so we got another question here. I got a 2-year-old infant male to the dermatology clinic with consistent severe episodes of photosensitivity and a immediate discomfort and erythema that is noticed upon minimal sunlight exposure. There's a reddish discoloration of the child's urine. Red teeth are noted as well, especially under a Wood's lamp. And the child is irritable and basically needs to avoid sunlight. So what is the following additional finding that you're most likely to find? So first I want you to think about the disorder. So we have a childhood presentation. Is it, and we have the red teeth and the red urine. So there's 3 things in this disorder: red teeth, red urine, photosensitivity. It is a childhood disorder. Yeah. So if you're thinking along the lines of CEP, you'd be right. So what's another manifestation of CEP? That's right, the anemia. Obviously, what can also help you a little bit is that this is a porphyria. So there is a inherent concern for anemia in all of these disorders to a degree. But in this one, more notably, a hemolytic anemia specifically is noted. That being said, the enzyme here, do we know what it is? It's a uroporphyrin 3 synthase. And now how do we remember that? There are 3 things I look for in this disorder: red urine, red teeth, and photosensitivity. So when I have those 3, and then one of those is urine, red urine is the uro part of this disorder. And then another thing you can think of is C is the 3rd letter of the alphabet, and the abbreviation has 3 letters. So I don't know, anything you can grab a hold of to maybe somewhat anchor this in your brain helps. All right, this one, a little bit more challenging. We're going to walk through this. A 5-year-old child presents to the dermatology clinic with recurrent cutaneous symptoms. These symptoms have started in her early infancy. That's not mentioned here, but I want to add that to help. Over time, those lesions have become a little more waxy and thickened. There's discomfort and pain in the abdomen as well. There are well-demarcated atrophic and hyperpigmented plaques on sun-exposed areas. Notable waxy appearance and thickening is noted as well. Wood's light examination demonstrates a protoporphyrin fluorescence. Laboratory investigations confirm elevated levels of plasma and fecal protoporphyrin. And then when we were talking about this question, what kind of 5-year-old tends to get cholelithiasis. So this part of the question might not help you. We added it in there just so to help, isolate. Oh, that's another finding to help clue you into this disorder, but also might not be seen this early on. So just a grain of salt with that one. That's what happens when I write the questions. So just keep that in mind. But basically, the keys here is early onset childhood disorder that has more chronic appearance over time with repeat photosensitivities. You don't have any redness in the urine or teeth noted. Specifically, you get waxier appearances as the child goes through cycles of this photosensitivity, and the child may or may not have a history of cholelithiasis. So, what enzyme is this? Now, we already went through one childhood disorder. It would be dumb for me to test you on the same childhood disorder again. So, get that one out of your mind, and then go for your thoughts on the next disorder. That's right. Yep, I think you got eyes on it. Yep, it's EPP. So what is the enzyme in EPP? That's right, ferroketolase. So EPP, your skin findings are pretty early, and then later on, after repeated trials of photosensitivity, they get thickened and waxier. Cholelithiasis might happen, especially as they approach, more towards adulthood. Now, here's the key thing, and I actually learned this from attending recently. There is no PP and EPP, so that means no porphyrias are noted in the urine, the PP of EPP. So that just is a good way of noticing that the urine test isn't too sensitive or specific, but the fecal protoporphyrin 9 finding might help you out. Alrighty, another childhood one. I know. It's almost like you're out of answers for this. So, a 1-year-old infant presents with a history of photosensitivity and skin fragility. The child's parents report that even brief exposure to sunlight results in erythema, swelling, vesicles, bullae formation over the sun-exposed areas, particularly the face and dorsal hands. Additionally, the infant appears well. Otherwise, laboratory investigations reveal elevated levels of protoporphyrin in the blood and uroporphyrinogen 3 buildup. The parents also note that the infant's urine appears unusually dark. So which of the following is the most likely diagnosis for this infant's condition? Now, we did mention dark urine. You can extrapolate. Is the author talking about red urine? Red can sometimes take on a dark maroon appearance. It's kind of confusing. But what should clue you into this disorder is the buildup, uroporphyrinogen 3 buildup. So it's not protoporphyrin 9, so you should already kind of exclude out EPP. XLP should be kind of excluded as well from this vignette. PCT should be excluded from this vignette as they're a child. Other thoughts could be CEP, but CEP is higher up in the cascade. It's not at the uroporphyrinogen 3 level. That leaves one answer being HEP. So let's highlight all the important things here. So the answer here is HEP. So take that, internalize that. I think the biggest giveaway with the last question would be the giveaway with the buildup. The metabolite buildup is what helps you out the most. Yeah, that's the biggest takeaway there. Now, things to note: immediate photosensitivity is noted. This is pretty rare, and you can get this, really early on as well. It's hard to differentiate HEP from CEP. The metabolite helps, so the uroporphyrinogen 3 buildup helps. Dark versus red urine can help you out a little bit. Cholelithiasis, and the other disorder can help you out a little bit. Actually, no, that's not true because cholelithiasis is an EPP. But there is an argument about what fluoresces and doesn't fluoresce. Some people may say that there is red teeth in HEP as well, but from our text in dermatology, the CEP pretty much carries the red teeth, red urine risk, while HEP just carries a darker urine, and likely you'll be helped out with the enzyme buildup as well. So, yeah, that's an important thing to note. Also, the enzyme here that's deficient is uroporphyrinogen decarboxylase. Um, Hint that is the same enzyme as PCT.